Welcome to this symposium to give you some of our results from the second joint action on dementia, Act on Dementia.
Good evening. It's my pleasure to present a summary, a short summary of what we have achieved all together for this work package dedicated to diagnosis and post-diagnosis support. With the patient's complaints or the situation at risk that may be detected by the GP with a dedicated consultation. Sometimes there is no cognitive disorder, but the GP has to propose some secondary prevention programs. Sometimes there is anxiety or depression that leads to specific programs, and sometimes the GP may detect a neurocognitive disorder, either a major neurocognitive disorder like dementia, or a mild neurocognitive disorders. And you can see that there is a graduated diagnosis process that will be adapted to each patient's needs and wills. So we tested these anti-stigma trainings, and there will be more details in the reports and in the paper, but you can see that this kind of program may move the stereotypes, may decline the stereotypes after the training program. So it was significant statistically, and it was very encouraging since the Polish team compared the academic and the new anti-stigma program, and this difference before and after the training regarding the stereotypes was only significant regarding the anti-stigma program and not for the academic program.
In Italy, we made a phone consultation between the general practitioners and the specialists operating in the memory clinic, or in Italy we call it as the Center for Cognitive Disorders and Dementia. In Netherlands, there was a Dutch pilot included in the National Dementia Plan, so the implementation of the action included in their plan. In France was the implementation of the mobile team specialized for the Alzheimer's disease, subject affected by Alzheimer's disease. In Scotland, they made a post-diagnostic support at the level of the primary care. Then in Bulgaria, they made some psychological intervention and psychoeducative program tailored to GPs and caregivers. In conclusion, which is the overall results of the whole work package? Is the creation of a specific and tailored care model about crisis and care coordination. The care model was focused on the listed hot topics. In particular, we made some interventions that are specifically patient-centered. So the patients assume the first role in all the work package and all the intervention that we have implemented. Another aspect important was the support at two different levels. The first level that was for patients and caregivers, and the second level for all the primary care support. All this implementation was then evidenced for enhancing the appropriate and adequate management, with the aim specifically to decrease the avoidable hospitalization. As we can see from in this slide, all the countries have implemented some action, have made not only one aspect of this care model. So no one country was specialized for this in all of these specific care model.
Good afternoon. I'm Øyvind Kirkvold, and I had the pleasure to lead the work in Work Package 6 about quality in residential care. We are several organizations that are also involved in this, from Norway, from Greece, from Netherlands, from Bulgaria, and from Romania. When we started to talk about quality in residential care, we saw that was a very broad topic. it includes everything. So we identified, for example, person-centered care, psychoactive medication, meaningful activities, comorbidity, or optimal medical treatment, activities, psychosocial support, skilled end-of-life care. How about the leadership, the physical environment? So we could have a lot of different topics to go into. But within the time frame and within what most of the members in our work package find to be most relevant, we decided, most of us, to go into behavioral and psychological symptoms in dementia, because this will mostly involve all of these topics. We aim a framework to evaluate. And this is quite important because this is also a tool for implementation. It's not only about evaluation, because if we have to see how do we reach the target groups, then we also can use that in the planning. Because if you don't reach those who are the targets, it have no use. And how to get efficacy or effectiveness. And that's about how to change attitude and practice. Adoption is how to, that this practice should be a part of the institutions. So it should be implemented as in the institutional level. And implementation in this program, we focused on barriers and facilitators. And maintenance is not so much to say about because we haven't had time to follow it up over time. And the conclusion about feasibility, in these three countries, Bulgaria, Romania and Greece, it was a high feasibility. It was accepted and they wanted to use it further.
The Department of Health and Social Care in England has been coordinating Work Package 7 on dementia-friendly communities, and I would emphasise the coordinating part. We've been working really closely with partner institutions in Greece and in Bulgaria, collaborating with partners in Italy, and also through Alzheimer's Society in England, drawing on lots of previous expertise and experience of developing dementia-friendly communities in England to inform the piece of work that we've been doing. So this work package has been about dementia-friendly communities, and that is to say, how do you make your community completely inclusive to people with a diagnosis of dementia? How do you make the reasonable adjustments that will allow people to live as independently for as long as possible at home? What my colleague Tessa is now going to talk about a little bit is the work to pilot dementia-friendly communities in different settings and some of the learning and experience that we've drawn from that process.
We found that one of the absolutely integral things of this, to ensure success of a dementia-friendly community is a really strong and robust network of organisations from a range of sectors. So individuals alone cannot put this into place. It has to have a high level of buy-in from people like politicians, local authorities, health and care professionals, and it has to be a real commitment from them. The nature of the site itself, including things like community ties and strength of family and who is actually doing the caring, really impacts the success of the community. So in places where there's traditions of caring for your own family in your own home, that may require quite a different approach to areas that tend to have people with dementia living in residential care. And finally, just to reiterate that again, that involving people living with dementia and their carers is absolutely essential. The key factors that our pilot sites would recommend other countries to consider, the things that are the most impactful. So that includes things like improving accessibility to community spaces, changing physical layouts, establishing caregivers education programs, educating community staff, signing memorandums and local agreements, using volunteers and training personnel.
I have just a few words to say around about dissemination. It's been very difficult to disseminate results until we had results. So this is the start of our journey for us to try to improve people's awareness of the joint action. And there are a couple of ways that we intend to do that. All the reports that have been produced throughout the 3.5 years of the joint action are available on our website. We've also tried our best to distill down some of the key findings into short reports. We have been greatly honoured by Alzheimer Europe to be allowed to have this time tonight, and also for all the efforts that we've received in terms of promotion of the joint action from Alzheimer Europe. But I think it's really important to say that we've all been working on this joint action because we're incredibly passionate about improving the lives of people with dementia and their carers, and that's been the basis of all the work that we've been doing. We wouldn't be here unless we believed that things can be improved. And as Jeff said this morning, it's not about strategies and writing more policies, because we all know what's the best thing to do. It's about how we implement it. And this joint action has really been about learning from different sites. And you've heard and seen the full range of participants from many different countries, different cultures, different health settings. But we think that there are some key learnings from those examples. And we felt that having short videos, having long reports for researchers and for those who really are interested in the evidence base, those full reports will be on the website, but also we've got some smaller packages to offer you.